Thanks everybody for coming. My job today was to talk about the sort of lumbar spine degenerative change and the lumbar spine nomenclature. Um, I do have another lecture that's sort of attached at the end. I don't think we're going to have time to do it today. Ewan has kindly arranged some lectures from our colleagues in Montreal as well. So I think you are going to get that later. Is it this fall, Ewan? Yeah. So I'm happy to go over it with you guys another time. It's sort of mostly like a case-based presentation. So happy to do that. But I think for the purposes of today, it doesn't really make sense to try to rush to get everything done in an hour. Lumbar spine degenerative change is super exciting. So we want to give it its due. I joke about it being super exciting. It may not be super exciting, but it is bread and butter. It is so much of what you do as not just a neuroradiologist, but any radiologist. I think it's really important to have a good understanding of it. I think where you work, it would be nice ideally to maybe have some discussions with your referring clinicians, like how, they like to see the reports and what sort of grading system they use. But there are some uniform descriptors that we should all be using, okay? So our objectives, we're going to leave out the spinal cord signal abnormalities. That's a whole nother lecture that you will have again, but we can go through it at some point if we have time. We're going to focus on lumbar degenerative change. Second, guys, I'm just going to close that so I can see better. All right, lumbar spine degenerative. Lumbar spine degenerative change. So this is a classic case that's going to come across your desk thousands of times a year probably. So we've got a nice sagittal T2, we've got an axial T2 image, you've got a large disc, and you don't like what it's doing to the nerve root. So again, I think it's really important to have an understanding of what the accepted descriptors are, what sort of some accepted scales for assessing spinal canal and nerve root compression, and for an understanding of what should go into a report. So let's just move forward, and we're going to talk all about those things, okay? And we'll come back to this case. All right, so the lumbar disc nomenclature, the first version came out probably almost 20 years ago, and I remember reading it as a resident. They did revise it, I believe, in 2011, and that, as far as I'm aware, is the most recent revision. So essentially, it was a combined task force of clinicians, of spine surgeons, and radiologists to come together to have a uniform type of descriptive process. So everybody's on the same page. We describe the disc the same way. We describe the locations the same way. I will say that grading stenosis is a little bit different, and they don't talk about it very much in this paper. But I would recommend all of our fellows have a look at this paper, spend some time to read it. Again, this is just such high yield, even if it's not hugely exciting, just based on the bulk of the cases that you're going to do throughout your career, okay? I'm happy to send you guys the link. It's not a long read, it's quite easy, but I would recommend it as part of your fellowship reading. I don't know if we have any residents joining us today, but also would be a good read for you. All right, so when we talk about disc degenerative change, we're going to discuss disc bulges versus herniation, the nomenclature, the localization, grading of stenosis. But there are obviously other findings that you see in degenerative change. So loss of disc height, disc desiccation, fissures, annular fissures, intradiscal gas, calcification, end plate osteophytes, and modic change. We're all going to touch on that as well. So this is a schematic of our normal disc morphology. So normally in the intervertebral space, you have a disc. We saw in our first sequence, the appearance of the periphery of the disc is typically darker in a normal disc. That's the annulus fibrosus. Centrally, the nucleus pulposus is a bit brighter. Again, that's in a normal disc. You can have disc desiccation, which we'll discuss as well. So this is our normal disc and posterior elements, and this is really the cross-sectional image you'll see on your axial T2. So disc bulge, how do we describe a disc bulge? I'll just say one thing. A lot of people still describe disc bulges as broad-based or focal. That was nomenclature, I think, from the earlier lumbar spine paper. In the second paper and the revised paper, they no longer said focal, broad-based. You'll still see it in some reports, but we'll go with what the most recent one is. So they talk about disc bulge, and a disc bulge is extension of the annulus, fibrosis, beyond the edge of the disc space on an axial plane. So usually it's about 2 or 3 millimeters at least beyond the edge of the vertebral body or the disc space. It's more than 25% or 90 degrees of the disc circumference, and it's not a form of herniation. So again, we're not going to talk about broad-based or focal disc bulge. We're thinking symmetric and asymmetric. So again, back to schematic, normal disc doesn't extend beyond the margins of the disc space of the margin of the vertebral body. This is a symmetric disc bulge, again, at least a couple of millimeters beyond the normal confines of the disc space, and this is symmetrical. If you broke it up, oops, my mouse is a little slow. If we divided this into 4 in all quadrants, you'd have a fairly symmetrical bulge of that disc. Asymmetric disc bulge is exactly that. It's asymmetric. And I think it's a good idea, like you want to say disc bulge or asymmetric disc bulge and larger from central to left extrafemoral locations to describe where it's asymmetric, or asymmetric disc bulge larger on the left, something like that. So disc herniation, it's acceptable to say in your report a disc herniation. You'll see some people put in HNP. I've seen occasionally, so herniated nucleus pulposus. Herniation is sort of an umbrella term and can be subdivided into 3 different entities: a disc protrusion, an extrusion, and a sequestration or a sequestrated disc. A sequestrated disc or sequestration is technically a subtype of disc extrusion. But again, you can say just disc herniation, but you do give a bit more information if you describe what type. A disc herniation, by definition, is displacement of disc beyond the edge of the vertebral body, but it's less than 25% or 90 degrees in the disc circumference. Degenerative change most commonly is at L4-5 and L5-S1, and you guys have probably seen that when you're doing your lumbar punctures and you're thinking, okay, what level looks good? Usually we try to go a level above. These are the most common areas. 90% of lumbar disc herniation will occur at those 2 levels. It's almost like the cervical spine where you see degenerative change, you can almost close your eyes and say it's worse at C5-6 and C6-7. These are the 2 most common levels. So here we go, disc herniation. Imagine you've broken your disc up into quadrants, so 4 segments, each quadrant representing 90 degrees or 25% of their circumference, and this is the herniated disc. A protrusion, again, herniation is the umbrella term, protrusion is one of the subtypes. It's a disc that's broader at its base than anywhere else in the herniated portion. So you can look on axials, you can look on sagittals. So at the base of the disc is larger than any other part of the disc. In reality, how important is it to describe or to differentiate a protrusion from an extrusion? It's probably not all that important. What the disc is doing is the most important part, but this is a lecture on nomenclature. So I think if you at least practice it and you do it correctly, then you at least have some internal standardization. So disc protrusion, it's a subtype of herniation, less than 25%, broader at its base than anywhere else. Disc extrusion, again, it's a herniation. So it's less than 25% of the disc circumference. In extrusion, it's narrower at its base than elsewhere in the herniation. So base is red, yellow is the larger part of the extrusion, yellow larger than red, that is an extrusion. A disc sequestration or sequestrated disc is technically a free fragment of disc material that's no longer connected to the parent disc. Now, I can see in real life, sometimes it's a little tricky to figure out if it's a sequestration or if it's an extruded disc. It's hard to tell sometimes if the two are still connected. The signal intensity of the sequestrated or the extruded disc can actually be different than the parent disc. And we'll see that in some cases later. It can be brighter on T2. That's not to say that it's something else. You don't have to start thinking, okay, well, that's too bright to be disc material because it doesn't look like the parent disc. It must be something else in my differential for extradural masses or lesions. That is quite a normal finding to see difference in terms of the signal intensity. All right, so localizing the disc herniation. This is also, so this drawing isn't from, I think this is from Radiology Assistant, but they did talk about a standard description in the lumbar spine nomenclature paper 2.0. They use a central location, so central zone or central canal, subarticular zone, so lateral to the central zone, medial to the pedicle, the region where the lateral recess is, a foraminal zone, and an extraforaminal zone. So you can see here, these are all disc herniations. They're all actually protrusions. They're bigger at the base than anywhere else. So these are the locations utilized when describing herniations. Disc bulges, I will say, again, if it's asymmetric, I'll say, imagine that this was one big bulge, so not 4 different herniations. I would say there's an asymmetric disc bulge larger from the central to right extraforaminal zone, something like that. I will occasionally do this, and I've seen lots of other people describe a paracentral location. I was watching on MRI Online Dr. Yusuf talking about localization, and he said, sometimes people use paracentral when you've got a central zone or central canal zone herniation, and it's a bit off to one side. So it's a bit asymmetric to the right or asymmetric to the left. So you will see sometimes paracentral, but it is not actually one of the descriptors for localization that they use in the official spine nomenclature paper. Alrighty, disc desiccation. Just like spine trauma from the summer, there are so many grading schemes. I don't want to say it's ridiculous. Obviously, someone has put a lot of work into this, but I think it's good to be aware that there are sometimes grading schemes, but also being aware that in practicality, you're probably not going to use them. There are some grading schemes that I know if I'm asked about it, I'll just look it up and give them the grade. I have never seen anybody grade disc desiccation. Usually my description is literally just like multi-level loss of disc height with disc desiccation, greatest at L4-5, something like that. But just so you know, there is a grading system. And let's talk a bit about the signal anyway. So this is the normal disc. This is the outer annulus fibrosus on T2. These are T2 images. It's dark, very dark, almost black. Centrally, the nucleus pulposus is quite bright. And as we increase in grade here, all the way to grade 5, you're losing presumably water content. It's getting darker. And then the grade 5 is very homogeneous, low disc signal. You don't see any discrete distinction between the annulus fibrosus and the nucleus pulposus. So usually it's just one line, there is disc desiccation, but understand there is a grading system. Some of the other findings in degenerative change. So intervertebral vacuum phenomenon, end plate osteophytes, end plate sclerosis. Maybe there's a little tiny cyst forming there and here. Sometimes residents will think vacuum phenomenon is like there's an infection and there's a gas producing organism. This is very common in degenerative change, so just keep that in mind. Obviously on an MRI, it may be a little bit harder to see than on a CT. You might see it on T1. And again, if I even mention it, it's just like, multi-level loss of disc height, disc desiccation, and vacuum phenomenon, something like that. Intradiscal fluid, we can see in degenerative change. It can be a little bit tricky if you've got a case of really advanced degenerative change and infection, trying to decide, okay, is that discitis or is that just degenerative change? And it can be problematic. I'm not sure if we talk about spinal infections or if that comes up in a lecture. at a later point, we could always discuss it and maybe, you know, how diffusion could be helpful, things like that. Disc calcification, don't see very often, but also possible. All right, annular fissures. So again, this is sort of a one word. There is an annular fissure or there's not. Again, probably not using tear. We're going to stick with fissure. Medical legally, probably more in the US, there could be, it could be problematic if you're saying tear, and then, you know, if a patient had an MVC and they had a follow-up MRI and there's an annular tear, you know, it could have some medical legal ramifications. So we're going to use fissure. Again, there is not necessarily a grading system, but there are different descriptors for the type of annular fissures. And again, I have never seen nor used myself anyone describe whether it's a radial versus a circumferential fissure. Really, for us, T2 weighted signal, hyperintensity in the disc, it's linear, it's curvilinear, annular fissure. Again, they can actually be symptomatic. They can occur acutely, but they can persist for weeks, months, years even, I have seen described. All right, so fissure rather than tear. Modig and plate degenerative change. There is a grading system, and this is one that I tend to use. I find it quite easy to remember. So Modig type 1, type 2, and type 3. Type 1 is, I think of it as more of an acute process with marrow edema. So our first image here is a sagittal T1 weighted image. Our second is a sagittal T2. On the sagittal T2, you have T2 hyperintensity in the end plate at which I'm assuming is L5. It's edema. So on T1, fluid is usually dark. So it's dark on T1. So dark T1, bright T2, that's Modig type 1. This is the one that can be most confused for infection. Modig type 2 is bright and bright. It's fat. We know that fat in the bone marrow, subcutaneous fat, is bright both on T1 and T2 sequences when there's no fat suppression. Easiest one to remember. And then type 3 is more of a long-standing process where you get sclerosis. So you have dark signal intensity both on the T1 and on the T2 sequence. So of all of the sort of grading schemes, for the lumbar spine, you know, this is one that people do use, or I don't know if it's grading, it's just typing. So type 1, 2, and 3, Modig degenerative change. Listhesis can obviously be quite problematic in the lumbar spine, can cause discomfort, nerve root, neuroforaminal compression, can be from degenerative change, and can be from pars interarticularis defects or spondylolysis, which we see here. Usually when it's degenerative change, you've got good going facet OA that's causing it. And I will specify if there is listhesis, I will say, is it anterolisthesis or retrolisthesis? I'll give the grade, which we'll talk about. And I will say whether I think it's degenerative or if there's a pars defect, because that is important. Occasionally on the MRI, it can be a little bit harder to see the pars interarticularis defects, but just remember you have the patient's folder to go back and look at. So go back and look. If you've got a previous radiograph or CT, go back and confirm that yes, there's pars defects, or you know, yes, it's probably just from facet degenerative change. So grading listhesis, again, this is one of the grading schemes that is fairly well used. So grade 1, you're looking at grading relative to the end plate, so breaking it up into quarters. So less than 25% slippage, so here it's anterolisthesis of L5 relative to S1, grade 1. Grade 2 is 25 to 50%. So you can see here, if you broke up your end plate into half, into quarters, you're slipped ahead more than 25%. Grade 3, 50 to 75% slippage. Grade 4 is 75 to 100% slippage. And then spondylolysis, which I can't say that I've ever seen. This is the S1, or we're going to assume it's S1 vertebra. This is the superior end plate. There's L5, and they're not even, their corners are just touching. They're not even in contact. So grading of listhesis is used, and this is one grading system that's, again, pretty easy to remember. Okay, so the most important part, really, of all of this discussion is really, what is that degenerative change doing to the nerve roots, to the spinal canal, to the neural, in the spinal canal and the neural foramina. We already talked about disc herniation and disc bulges. We talked about spondylolisthesis and how that can affect, well, how we grade it, and that it can affect the spinal canal and neural foramina. Two other things that we'll just discuss before we move on to sort of grading. So facet joint hypertrophy, there is actually a grading scheme which we'll go through for mild, moderate, and severe. And then ligamentum flavum hypertrophy, some purists will say it's not hypertrophy, it's not an increase in cells, it's just thickening. I tend to say thickening of ligamentum flavum. I think if you say hypertrophy, people understand what you mean, but just understand that some people could take issue with that term, hypertrophy. Alrighty, lumbar spinal canal stenosis. I wish, the one thing I wish from the lumbar spine nomenclature 2.0, I do wish they had spent maybe a little bit more time on talking about stenosis and grading it. I think what, if I can't remember the paper now, what they were supporting was the use of, I believe it would technically be the Lurie classification, where they use how much the central canal is compressed relative to normal, and it's in thirds. So mild being 1/3, moderate being 1/3, 2/3, and then severe being greater than 2/3. And I suspect a lot of people do use that. Some of the other classification systems for lumbar spinal canal stenosis. So Lee has one that I find quite easy to understand. We'll have a look at that in a second. Park as well. So just understand, and again, I think in an ideal world, if you start at a new hospital, you might ask the spine surgeon, like, hey, I want to make sure that I'm uniform in terms of how I'm describing my spinal canal stenosis, and I'm going to use X system. And here is what X system is, either 1/3, 1/3 to 2/3, greater than 2/3 for mild, moderate, severe, or there's this other grading system. Are you okay with that? In reality, I'm not sure that happens too often. I can't say I have asked our surgeons if they're happy with my grading system. I would be curious if Ewan had any comment on that from London, but
I've asked some of our stroke neurologists how they like my reports, but never the spine surgeons. But I think we should ask them. I'd love to know.
Yeah, like, are you guys, to be fair for the learners, I mean, an image is worth 1,000 words, right? Is that the term? They're looking at the images as well. But it would be nice, I mean, even among the neuroradiologists at our site, Ewan, maybe we should just say we're going to use this system, and we're just going to talk to the chief of surgery and just say, this is what we want to use. Are you happy with it? And here's like a summary of kind of what the findings are. That might be a good idea. We can talk about that.
Totally.
There are a number of grading systems. So this is Lee, which I do like, and I used probably up until a couple of years ago. The only thing I don't like is the number grade. I don't think the spine surgeon is going to be happy if I say there's grade 1 stenosis or grade 2 stenosis at this level, unless at the bottom I have like a little descriptor of what each one is. But anyway, I like, apart from not liking the numbers, if you just change it to grade 1 being mild, 2 moderate, and 3 severe, I think the way that they determine the stenosis is great, and it's very similar to the one that I use, which we'll talk to next. So normal. These are all axial T2 images of the lumbar spine. This is a normal disc. Again, you can see nicely the bright nucleus pulposus, the dark annulus fibrosus. You've got facet joint and ligamentum flavum. You've got the paraspinal muscles, and we see the nerve roots sitting in that thecal sac, lots of CSF. The morphology looks great. You've got a concave disc. You don't have thick ligamentum flavum. Everything looks perfect. So this is normal, no crowding of the nerve roots. Mild or grade 1, they describe here, you've got some effacement at the ventral aspect of the thecal sac, but you can still see nerve roots, and you can still see CSF around them. Grade 2 or moderate, you've got more compression of the thecal sac. You've got some clumping now, some aggregation of the nerve roots, whereas before you could see them distinctly. Now you've got some kind of stuck together. And then severe, you've lost really essentially all the CSF. The nerve roots are more clumped, more aggregated. I think everybody would agree with severe, moderate, and mild, whether or not you know that you're using the Lee classification system. This was a really nice paper that one of our previous fellows brought to my attention a few years ago after it was published. So Miskin and Mendel, their grading system, which we're going to go through, I actually quite like. It's very similar to Lee. This came after the most recent lumbar spine nomenclature paper, so wasn't obviously discussed in there, but I think this is a great paper to add to your reading. If you're going to do a little bit of reading about lumbar spine degenerative change, which again, it's not super exciting, but it is great yield given on how many of these cases you're going to do, add this one to your list. It's a great paper. It's easy to read. We're going to go through how they grade Meskin and Mendel, spinal canal stenosis. All right, so here we've got, again, axial T2 images, and then we've got nice diagrams. So the normal spinal canal, this is our thecal sac, the dura, the CSF, all of the nerve roots. So you've got normal distribution of the nerve roots in the central canal. These are the traversing nerve roots in the region of lateral recess. So normally you've got free distribution of the nerve roots. There's no crowding. The traversing dorsal and ventral nerve roots, you can see distinctly. You can see two separate nerve roots on the lateral recesses. You've got a normal, either flat or slightly convex shape of the ventral thecal sac right here, this black line where number 3 is, and the epidural fat is preserved. Mild spinal canal stenosis, so again, Lee would have said grade 1, but mild. You've got slight crowding of the nerve roots. The dorsal and the ventral nerve roots are a little bit less distinct, but you can still see them individually. You've got a little bit of cavity now, or flattening of the ventral thecal sac. Before it was a bit convex here. Now this is showing concavity, or it's flattened. The epidural fat is still preserved. So I would call this mild. And again, I was doing this even before the paper because I was using Lee's method and just doing mild, moderate, severe. But definitely I would identify myself now as using Miskin and Mendel. Okay, moderate spinal canal stenosis. You've got the ventral aspect of the thecal sac is concave. You've got crowding of the nerve roots. They described it as a speckled appearance. I mean, to me, this is still kind of speckled, so I'm not sure I understand exactly that. But the nerve roots are crowded. They're not dispersed normally in the CSF as they were before. It's harder to see if you've got traversing nerve root. It's harder to see the dorsal from the ventral nerve root. The anterior margin, again, is concave, not just flat and not convex, certainly. And the epidural fat still is usually preserved, so moderate. Severe spinal canal stenosis, you've got, again, this concave appearance of the ventral thecal sac. Your CSF now is essentially gone. I sort of reserve severe for the CSF is effaced in its entirety. I would argue maybe there's a tiny bit of CSF here. This to me is still essentially effaced. Absolutely, I would agree that would be severe. You can't discretely see the nerve roots. All the CSF is effaced. It's just a big blob stuck together. The anterior margin, again, we said is concave. And then the posterior epidural fat can be partially effaced. One thing I forgot to mention, we talked about sort of all the things that contribute, degenerative changes that contribute to spinal canal stenosis. I didn't mention epidural fat. And I didn't mention developmental narrowing of the spinal canal. So epidural fat, it's normal to have some epidural fat dorsally. In epidural lipomatosis, where there's too much epidural fat, that can certainly contribute to spinal canal stenosis. And I think it's a very valuable thing to add in your report if you see it. So what I would say sometimes could be that there is, disc bulge, facet OA, ligamentum flavum thickening, and prominence of dorsal epidural fat or epidural lipomatosis that all contributes together to severe spinal canal stenosis. So I may say something like that. And then there are developmental conditions where you can have narrowing of the spinal canal, for example, short pedicles. So usually in that instance, I would say sort of at the top of my report, like there's developmental narrowing of the spinal canal at, X level from whatever it is, short pedicles or whatever. And then when I'm describing each level, I would say, just like this case, there is developmentally narrow, if this was the case, a developmentally narrow spinal canal, disc bulge, facet OA, thickening of ligamentum flavum, prominent epidural fat which altogether results in severe acquired undevelopmental spinal canal stenosis, something like that. I think it's valuable to tell the physicians if there is developmental spinal canal stenosis, they're obviously at risk more of being symptomatic more than a patient who has, capacious spinal canal or normal space. So those are the two additions I would add in terms of all the things that can cause spinal canal stenosis, or most of the things. I would just include that in your thought process as well. Okay, so lumbar spinal canal stenosis. I've never seen anybody say in the report they're using Miskin and Mendel, but I think a lot of RADs do use this, or they use the 1/3, 2/3 sort of discriminator. Neuroforaminal stenosis, Lee has a nice descriptor, again with numbers. I do not use the numbers, but I use mild, moderate, and severe using sort of their process. So this is your neural foramen. You've got the nerve root or the dorsal ganglion, which most of us just kind of, we won't say dorsal ganglion is compressed, we just say the nerve root's compressed. But so this is the nerve, and this is the fat around it. This is the ligamentum flavum, that's the facet joint, there's the disc and the vertebral body, so you know what we're looking at. So for mild, their grading classification is effacement of the fat, or I guess technically abutment of the nerve in one plane. So whether it be AP, whether it be a craniocaudal, just in one direction, or narrowing the fat, I guess, on either side of the nerve, so in two planes. So this is mild. Moderate is you've got narrowing of, effacement of the fat in all around the nerve, or abutment of the nerve in two different planes. So you don't just have AP or craniocaudal, you've got both, but the nerve is not compressed. The morphology is preserved. For severe, you've got essentially obliteration of the fat surrounding the nerve. You've got deformation of the nerve. So this is Lee's grading scheme, which I do. This is what I use. Again, I don't include in my report that it's from Lee, but this is probably what most RADs use. Miskin and Mendel have their neuroforaminal stenosis grading scheme as well, which I quite like. And it's very similar. So for mild, they give a couple of examples here of mild. So you've got nerve root in contact with the wall of the neural foramen. So the fat is effaced, just like the last case. They're just describing it a bit differently, in either one plane, so AP here, or craniocaudal, or in three planes, so three different sides. Aside from the narrowing the neural foramen in contact with the exiting nerve, the epidural fat's otherwise preserved. So that's mild. So very similar to Lee. Moderate, same thing. You've got effacement of the epidural fat, or you've got contact of the nerve in two planes. So not just one, not just three, two. Not just one with the third. I guess technically here it's two planes in that it's one plane being AP and one plane being craniocaudal, but touching the nerve on three sides and effacing the fat. That's moderate. And then severe, you've got compression of the nerve, you've got obliteration pretty much entirely of the fat. I think grading the spinal canal stenosis, from my experience, RADs in the city are pretty, they're fairly uniform in terms of how they grade it. Neuroforaminal stenosis, I would say, were not so uniform. Severe, I find easy. The nerve root's compressed. Typically, I reserve it for where there's essentially no fat. Moderate and mild can be a little bit harder. I would argue that some patients, they don't have any loss of the fat around the nerve. They don't have any contact with the wall of the neural foramen, no contact at all on the nerve, but the inferior neural foramen is narrowed. You've got disc pooching out here. And I find it really hard to call that normal, because it's not a neural foramen. It's not a normal neural foramen, but the nerve root is fine. So sometimes I'll just say, you've got a bulging disc, mildly narrowing the lower aspect of the neural foramen, but no nerve root compromise, something like that. So I think it's going to be up to each of you as practicing radiologists to decide what grading system you want to use, recognizing that these are both very similar. And to be honest, you're probably not going to spend time too much trying to determine, are you going to be really upset if you call this mild and someone else calls it moderate? Probably not. But at least if you decide what you're going to use and then you have some internal consistency, I think that's the most important thing. All right, so lateral recesses and how we describe what's happening to the nerve. So if the nerve is just touched by disc, it's contacted, but they're not compressed, the term that's probably best to use or nice to use is abutment. So abutment of traversing nerve. If the nerve is compressed and if it's displaced, we should say that there is a difference technically. Now I will say one thing, all of these studies, everybody is scanned supine. So you can imagine when the patient is standing, when there's an axial load, things may look a little bit differently. So sometimes I think, okay, this isn't so bad. The nerve is abutted, maybe they're not symptomatic. When they're standing, it could be compressed, it could be displaced. So I think it's important for us to remember that what we see is not the end all or be all. You really need the clinician to correlate with, okay, we see that this nerve looks compressed. Does that match your physical findings? I think it's important for us not to sort of overestimate in our minds like the patient's symptoms or overestimate or underestimate. That was an interesting point that, again, Yusuf said in one of his lectures, that probably things look a little bit different. So just keep that in mind. For the clinician's description of the symptoms, sometimes I think, why am I not seeing a bigger disc there? and maybe that's part of the reason they're supine. There's no axial load. Alrighty, so now we've been through some different types of spinal canal stenosis. And again, I think Miskin and Mendel is my favorite currently. A couple of different types of neuroforaminal stenosis grading, which are essentially the same, Lee and Miskin and Mendel in my mind. And then talking a little bit about lateral recess stenosis. I can't say that I've seen a mild, moderate, severe grading for this, but sort of being present or absent. And I think the most important thing is just what's happening to the nerve. And I apologize, I didn't even show you the images. So abutting the nerve here, so it's not displaced, doesn't look compressed. And then here, this nerve is compressed. This one is, both are displaced actually. Alrighty, so grading of facet OA, mild, moderate, severe. I don't know. I do tend to say severe facet OA, and then otherwise I just say facet OA. So I think it's up to you to decide how you want to describe facet OA. But we'll just go through some of the parts here. So small osteophytes, a little bit of irregularity of the subchondral surface, tiny subchondral cyst, mild. Moderate to me looks almost identical here to the image of mild, but bigger osteophytes, more irregularity of the subchondral surface, moderately sized moderately sized cysts. Effusion in the disc space can occur, and in here they're preserving that for moderate or severe facet OA. Facet OA that's severe, bigger osteophytes, larger subchondral cysts, more irregularity. Again, sorry guys, my mouse disappeared. So here they're showing some joint effusion. In the same way that Modig type 1 degenerative change, disc edema, it can be a little bit complicated if you've got those findings and you've been asked to determine if there's an infection. Sometimes facets there can be very severe degenerative change. There can be joint effusion. You can have edema around the facet joint. If you've given GAD, you can have enhancement. That can all be degenerative change. So you do have to, I guess, think about what is their level of suspicion. Is there anything else I can use to help? Diffusion technically in the vertebral body can be helpful. Is there an abscess? Epidural or paraspinal. So just keep in mind, there is a grading system for describing the severity of facet OA. I'm not sure how often people use it. Okay, so let's just go through a few cases now that we've got our nomenclature down, our grading down, or at least we know what the different grading systems are and we're going to decide which we use. Let's just go through a few cases. So this is the first case that we had. Before we move on, let's just, in terms of how to formulate or review a report, I will tell you how I formulate mine, and then you can decide whether you like that and what you're doing with other radiologists. So typically what I do is I give them a count. So if I have, again, if I have previous images, I'm looking at them. Most of these patients, will have, maybe not most, but a lot of them will have previous radiographs and CTs, and that's really helpful. You don't have to stay on every lumbar spine. 5 lumbar type vertebral bodies are presumed. You can look back, and I will say, based on the previous CT, there are 5 lumbar type vertebral bodies, or there's a transitional, block. So first I describe the number, then I look for the alignment. So do we have any listhesis? We know that listhesis can be caused from degenerative change, usually at the facets, or pars defects. Are they present or absent? Vertebral body heights, bone marrow signal. Okay, well, I've got some bright signal here on T2. I'd pull up my T1 sequence. Is it also bright? That's modic type 2 degenerative change. Is it dark on the T1? That's going to be modic type 1 degenerative change. So I talk about the marrow signal. I talk about the disc heights and disc desiccation. So here I'd probably just say, mild loss of disc height at L5-1, L5S1 with disc desiccation. And then I usually will include a comment about where the conus medullaris terminates, what it looks like. If you've got distal thoracic cord, what does that look like? Very rarely, but it does happen. You can have a lesion there, right? So you don't want to miss that. The other thing that I look for is flow voids in the spinal canal. We've had a few cases where on the lumbar spine, you can actually see the flow voids in these big vessels in cases of spinal dural AV fistula. So have a look there. And then typically I go level by level. Ideally, your MRI is going to include probably from about T11 to the mid to lower sacrum. And I might just get the lower thoracic spine on SAG images, and I'll say, based on the SAG, there's nothing or there's a small disc. And then I go level by level. So in this case, I'd pretty much say on this one image that everything is almost normal until here. Sure, maybe there's a tiny bit of disc bulging. I'd look at the axial images, but I'm not too excited except for this level. So at this level, we have a disc herniation, right? Break that disc up into 4. It's less than 25% or 90 degrees. This is not a bulge. It is a herniation. Now, can I tell them, is this an extrusion? Is it a protrusion? Is it sequestrated or a sequestration? If you look on the sagittal images at the base of the disc, it's definitely narrower than sort of at the dome or the larger part of the disc. So, I probably call this an extrusion. On the axial, it looks more like a protrusion. On the SAG, I'd say probably extrusion. Again, I really don't think that part is hugely important, just that you understand there is a difference, so that you can sort of, decide yourself and have some internal consistency. Alrighty, so we've got a disc herniation.
Dr. Candy, here from the sagittal, it looks like more extrusion, and from the axial, it looks like more protrusion. So which one?
So this one I would probably just pick extrusion. I think based on the sagittal, to me, it looks like extrusion. So I think this one I would just call extrusion. You're right. Again, what the disc is doing is probably much more important, but I wanted to make sure you guys knew what the difference is so that you have some internal consistency, but I don't spend too much time worrying. There are some discs and I'm like, darn it, is this a protrusion or extrusion? From the paper, the nomenclature paper, I think they say if in any plane it's narrower at its base and wider in another dimension, you would call it extrusion. So it doesn't have to be on both planes.
Shauna, I'm really sorry to interject. I don't understand. To me, whether it's the sagittal or the axial, the base is wider, which makes it a protrusion. How is this an extrusion?
So the base, sorry, I guess I'm saying base, but it's the contact with the parent disc. So if you look at the contact with the parent disc, it's right here. And if you look further out in the disc, it's wider. I agree on the axial, it looks like a protrusion. It's definitely wider at the base than it is here. I will tell you guys, I was actually, again, I had looking through my MRI online, some of my MRI online talks, and when Yusuf, he would have called this a protrusion. And when I look online at the lumbar spine nomenclature paper, when I look on Radiopedia, they would call this an extrusion. So I'm going to apologize. Maybe I can dig into it a bit more. If I go from the nomenclature paper, if I'm looking at the parent disc, definitely the contact is narrower than the rest of the disc, so extrusion. But I do not disagree, Derek. I have seen other papers where they would say, well, it's not, it's actually the base of the disc rather than the contact with the disc space, so this must actually be a protrusion. I will look into that for you guys. But okay, why don't we just call this a herniation? I would have called this an extrusion, but a herniation. So we've got a herniated disc. We're at L5S1. These are the traversing S1 nerve roots. So we've got our disc. We've decided it's a herniation. Now we're going to talk about the location. So central zone would be a disc that was just here. Subarticular zone in the lateral recess would be a disc right here. And then foraminal and extraforaminal. Whoops. So I would argue, I don't know what you guys think, that probably it goes from the central zone, involves the subarticular zone, and probably goes to the foraminal zone. So however you want to describe it, you could say a disc herniation extending from the central zone to the foraminal zone. You could say because the majority of the disc where the problem is the subarticular zone. I think that would be fair to say as well. I probably would just say that this is, a left subarticular disc extrusion. And if you look at the nerve root, you've got, we talked about the terms abutment versus compression and displacement. You've got a nerve that is compressed. So this is disc margin here, I would say, and this is the nerve. So the nerve is compressed and displaced. So my report would be, I've got an L5S1 left subarticular disc extrusion with compression and displacement of the traversing S1 nerve in the lateral recess. And then you could say, not only is this nerve root pinged, but if you look at the thecal sac, you've got some compression and probably those nerve roots are a bit crowded. So you could say there's also mild narrowing of the central canal or effacement of the thecal sac with minimal crowding of nerve roots laterally. So I suspect clinically the biggest area of concern is going to be S1, but the lower sacral nerve roots could also be affected. All right, I think we would all argue extrusion here, or not? Anybody want to go against the grain? So if you look again at the parent disc contact, I think I even, don't measure it in the next one, definitely narrow than the widest point of the disc on any plane. Disc extrusion. And that last one, again, I will look into it, guys, and see if I can find a better consensus. But to me, based on the paper, it would be extrusion. But Derek, I do not disagree that I have seen other people, instead of contact or communication with the parent disc, use like the base. I have also seen protrusion. So disc extrusions can migrate. Protrusions should not migrate. So you shouldn't have any disc above or below the disc space. But again, I don't disagree. I have seen some confusion between lectures that I've watched and the literature. Alrighty, another case, 35. Okay, so we've got some more images here. We've got a sagittal T2, two slightly different planes, and we've got axial T2. So now we've got, again, normal alignment. We've got some hyperintensity here. We check our T1. Is that modic type 1? Is that modic type 2? We've got disc desiccation of the two lumbar vertebra. We've probably got little annular fissure. We're not going to call it a tear. We've got, maybe a bulge here. We check out the axial, but really the concern here is at 5-1. So we've got a disc. If you look on the axial, it's definitely less than 25% of their circumference, or 90 degrees. So this is a herniation. If you look on the axial image, it does look like it's wider at its base where it contacts the parent disc than anywhere else. But if you look on here, definitely this looks like an extrusion. So if we look where the disc contacts the parent disc, it's definitely more narrow than it is in this greatest dimension. And again, it's migrating. It's migrating inferiorly. A disc protrusion shouldn't migrate like that. So now we've got extrusion. When we think about extrusion, we also have to think, okay, sequestration is technically a subtype of disc extrusion where the sequestrated fragment does not contact the parent disc. They can be challenging to differentiate. In this case, I would say we do have one image where it looks like it's contact, but we have another image, and if we were able to scroll through, you could see that it's likely not in contact. So we could call this a sequestrated fragment. We talked about the signal being different. So the parent disc here is desiccated. It's dark. This is bright. This doesn't concern me at all for a disc. It doesn't make me think this has to be something else than a disc or that there's an infection or something. This is very common. If you look on the axial images, I don't even know that I gave you a great image, but this is actually all disc because I remember the case. The thecal sac is like very squished back here. So if we were going to grade spinal canal stenosis, if we were looking at just this image and we didn't have the lower image, you might just say mild. You've got concavity in the ventral aspect of the thecal sac, maybe a little tiny bit of crowding of the nerve roots, but you still see them and you still see the CSF, but definitely lower. And I apologize, in real life, you could see how compressed the thecal sac was. We would call severe. All right, so these discs, whether we argue about extrusion versus protrusion, these ones are kind of fun to get because you're like, well, that's it. That's absolutely the level of symptom. They're very satisfying. I would say most of the time it looks more like this. So you've got multi-level disc desiccation. You've got loss of disc height. You can see there's end plate osteophytes, subchondral cysts. This is a much more diffusely degenerative spine. So here you've got a disc bulge. You've got facet OA. Could we call it severe? Probably. We've got pretty big osteophytes. You've got subchondral cyst. You've got irregularity of the articular surface. You've got thick hypertrophy. Again, you can call it, thickened flavum. Again, you can call it hypertrophy, but technically the cells don't actually, get more cells or increase in size. And this is compressing the thecal sac. Don't see really any CSF. The nerve roots are aggregated. I think most of us would agree to severe. If we look at the neural foramen, you do still have a little bit of fat surrounding the nerve root. A little bit of fat surrounding the nerve root. This one, I would argue that the nerve root is actually deformed. It is compressed. And the fat, yes, there's a tiny bit, but it's essentially gone. I would think I would call this severe. Similarly here, I think you really need to be able to scroll. I'm not sure if I would call this, it looks the same as a level above. The nerve root looks compressed. The fat's almost gone. I would call severe. Here you've got contact effacement of fat, maybe just in one direction, mild. I can't really see the other ones well enough.
Shauna, can I just interject? Can you go back 1 minute? I don't understand the foraminal, no, not the foraminal, where you've got the points of, where the disc is tightened in its lateral recess. You used another, subarticular. Can you go back to that the SAG image you had a minute ago? So when you say subarticular,
that's for the location. So that's a disc can be central, subarticular, foraminal, or extraforaminal. Okay.
So subarticular meaning below what? Is it below the pedicle?
It's medial to the pedicle. I think it's sub relative to the facet joint.
I see, sub relative. Yeah, I've never understood that. So
no, I know, Derek, subarticular. I'm going to admit it is not my favorite. Everything from that paper, lumbar spine nomenclature paper, I find super helpful and useful, but subarticular is one term that I don't love. And I can say a lot of the radiologists in this city don't use it. Sometimes they'll say paracentral or lateral, but it is technically the term they suggest is subarticular. Yeah.
Okay. And just on this image, in case I forget, why does that sequestrated disc look so different in signal intensity? How do you know that's the mass line?
Yeah, so that's very, very common for extruded and sequestrated disc. I don't really know, Derek, exactly the pathophysiology, but it is very common to be different in signal and usually brighter than the parent disc.
Lovely. Sorry to disturb. Thank
you. Yeah, no worries. But yes, that's a great point, because sometimes you're like, well, that can't be a disc. It's a different signal, but that's a very common finding. I can look up the actual pathophysiology. All right, so this is one other thing. Almost done here, guys. Sorry, it's taking so long. One other another entity that can cause degenerative change we haven't talked about yet. Okay, so if we go through this case, we're going to start with our alignment. We're like, oh, okay, we've got grade 1 anterolisthesis of L4 and L5. In real life, you'd be able to check out the the pars interarticularis to see if there's a defect. You'd check out the facets to see if there's OA. Vertebral body height's fine. You've got some bright T2 signal. You'd check your T1. Is it fat? Is it edema? Some type of modic degenerative change, 1 or 2. You've got disc desiccation, loss of disc height, and then we've got this. So if we look on our axial, we've got facet OA, we've got fluid in the facet joint, we've got thickening of the ligamentum flavum, and then we've got this lesion. So facet synovial cysts are typically T2 hyperintense centrally and have T2 hypointensity along the periphery. They can absolutely cause problems. You can see here that the spinal canal is compressed. What do you think? Would we call that moderate? Is it severe? I still see some CSF, but the nerve roots are definitely aggregated. So more than mild, I suspect I'd call it moderate in real life. So I would describe all of the degenerative change in terms of the disc, the facet, the flavum, and then say also that there's this large facet synovial cyst. All together, I've got moderate degree of stenosis, and then I would look at the neural foramen, obviously. So facet synovial cysts, occasionally you can see them on CT. On CT, sometimes they actually have a little bit of spontaneous hyperdensity in the facet synovial cyst, and this is a classic appearance on MR. Bright T2 centrally, dark T2 along the periphery. Vertebral count, I'm not going to go through this because I just wanted to talk about one other thing. But again, if I can make a pitch for, look in the patient's jacket, did they have an old x-ray that can help you? Do they have a previous CT? You don't want to be involved in a wrong level surgery for the surgeon. Doesn't happen very often, but it's possible. The most important thing is you tell the surgeon how you're counting. Like, I'm considering 5 lumbar type vertebral bodies, or there's a lumbosacral, a transitional sacralized L5 with 4 non-rib-bearing lumbar type vertebrae. As long as you're clear in how you're counting, I think that's the most important thing. And again, if I can just suggest, have a look at the x-rays if possible. Report preferences. So in terms of thinking about your audiences, it's important. If you're sending this to a family physician, any suggestions for management like surgical referral, or if they need additional imaging can be helpful. The specialists, based on this paper, typically don't necessarily want specific recommendations. They just want a good review of the radiologic findings. And again, I think it would be useful, deciding in your department how you're going to grade the stenosis, what system you're going to use, and maybe discussing with the surgeons. So here's our last case. I gave you a SAG T1 this time. Haven't been seeing those, and an axial T2. So the vertebral bodies look fine. The marrow signal okay. The disc height looks okay. Nothing looks too bad in the spinal canal. But we're not just looking at these in isolation. You have to look around. So you look at the psoas muscles, the paraspinal muscles. These can be really important for if you have infection. So looking for myositis, bright signal in the muscle, or abscess. But look in the retroperitoneum, you've got these dark structures. I remember doing this and thinking, what the heck are these? Are these like black lymph nodes? I've never seen lymph nodes so dark. And because I went to the patient's jacket and looked at their previous CT, I saw that he had cirrhosis, and these are actually huge varices. So this is just another pitch to look at things outside the spine. Extraspinal findings occur in about 30% of cases. Most of the time it's stuff that doesn't really matter, like little renal cysts, maybe even little hepatic cysts, but occasionally you will find very significant things. In that patient, had I not known, or had it not been known that he had cirrhosis, it would have been very important to find these and say, like, he needs a further workup. I don't know if these are very dark or like fibrous lymph nodes. Are they varices? A few other things that I've seen, these are cases that I've had, so things you don't want to miss. Retroperitoneal lymph nodes, so see how much brighter this is compared to that last case. Just remember that, black varices. So lymph nodes, you can see them here. Retroperitoneal hematoma. You can see the psoas muscle is asymmetrically larger and brighter, and there's some blood around there. Renal cell carcinoma. One of my colleagues once got a thank you card from the patient for finding his renal cell carcinoma, and I have found it before and have never gotten a thank you card, but it was such a nice gesture. So renal cell carcinomas, you know, it's not a common find, but I've only been in practice 10 years and I've had one. And I've seen, you know, other ones that other rads have found. So please look at the kidneys. More commonly, you're going to have cysts. Femoral head avascular necrosis. I was also super excited about diagnosing their femoral head AVN, and it was already known. They had it on a previous CT and they'd even had a hip MRI. When you're looking at the C-spine, have a look at the humeral heads. Lumbar spine, you're not going to get the shoulders, obviously. And what was this one? Oh, a psoas tumor. This was a nerve sheath tumor, a case from Joe's, actually. That one wasn't mine. I'm going to just take another 5 minutes because we talked about this. Okay, cervical spine. So today was technically the lumbar spine degenerative. The Nomenclature paper 2.0 really just does cover the lumbar spine. The description of the location of the disc is transferable. Herniation, bulge, I think transferable. Just keeping in mind in the cervical spine, often you've got osteophyte as well. You can differentiate if you have an axial gradient sequence. You can sometimes differentiate what part is disc, what part is osteophyte. We used to always get an axial gradient, and then for time's sake, because we're so behind, we have excluded it, except we do in trauma cases. Cervical spine, a lot of people will just say disc osteophyte, but they'll still say if there's a more focal finding, like a herniation, you can use the same terminology in terms of the location. So this is a case where you've got quite a bit of spinal canal stenosis. You've got some degenerative process here. Is this just disc? Could it be ossification of some other sort? Another thing I would suggest, if you ever have a concern on an MRI, for ossification of the ligamentum flavum, it's fairly easy to get a CT to confirm. We've had a lecture, it was maybe Dr. Bedner years ago, just about how important it is for the surgeons because it can affect their approach, anterior versus posterior, if there's ossification of the ligamentum flavum. Ossification of the posterior longitudinal ligament can be more problematic for the surgeon. So if you suspect it, best just to do the CT to confirm. And then, okay, cervical spinal canal stenosis. We may just have to have another lecture. There is a grading system. This is the one that I use by Kang. Again, they use a number grade. I've never seen anybody use a number grade in the cervical spine, but the description is helpful. So normal, you've got spinal cord, you've got CSF, you've got space on both sides, neither are effaced. It's normal. Mild spinal canal stenosis, or what they describe here as grade 1, you've got here disc and ligamentum flavum that are protruding into the subarachnoid space, and you've got obliteration of one or more, so anterior or posterior, of more than 50%. Now, in real life, do I measure? No, I don't. But I can tell you that it's not normal. I don't have any deformity of the cord, and I don't have any myelomalacia. So likely it's going to be mild. In this grading system for moderate, you've got effacement of the CSF, but they also have some deformity of the spinal cord without cord signal abnormality. And that's what they use as moderate. For severe, you've got disc here compressing the spinal cord, but not only that, you have signal abnormality with myelomalacia. I think most people do reserve spinal canal stenosis being severe as having this signal abnormality. Moderate, I find a bit trickier. I suspect there are some times that I've called mild spinal canal stenosis moderate. I don't know if Ewan has any comment on whether we're as consistent in the cervical spine asthma, but there is a grading system, and I do tend to use this and reserve severe spinal canal stenosis for when there's cord deformity and signal abnormality. Again, it's important to just have some internal consistency.
Yeah. Sometimes, Dr. Candy, we just saw like even in cases of just straightening of the cervical spine, the anterior epidural space is completely effaced. You can't see any CSF space, but
Yep.
no like significant compression, and still we can see enough space and posteriorly. So, on that, occasion, what should we describe? Because we used to see like some cases in which there is like complete effacement of CSF space anteriorly. Maybe that due of just significant straightening of cervical spine, which could be just positional.
Right, positional, yeah. You're right. You can have a cervical spine where they're very straight and they have no degenerative change, and the thecal sac, like the CSF, is a bit flattened. In those cases, I might just say like they're straightening. There's some effacement of the CSF surrounding the spinal cord, but there's no degenerative change as the cause. There's no cord compression or myelomalacia. And I probably would leave it at that. I wouldn't say necessarily that there is stenosis. I haven't thought about it recently. Yes, you can have developmentally narrow cervical spinal canal as well, but I don't have a measurement per se in terms of determining, whether it's present or not. But as to your point, if you just have like a straightened canal and it does look a little bit effaced, I might just describe it just as being effaced, but it's not degenerative. There's nothing compressing the cord and there's no cord signal abnormality. Is that sort of what you were getting at?
Yeah, thank you.
Yeah.
Can I also ask, this maybe a silly question. So there's posterior epidural fat. Is there also anterior epidural fat, or is there nothing anterior, like no fat?
Venous plexus anteriorly, but no, I don't think there's usually fat. I think it's posterior.
Okay,
I guess
thank you.
Within the lumbar spine lateral, yeah. Okay. So an example here. So yeah, I guess this is sort of what we were talking about, right? This person doesn't have a really straight spinal canal, but if you think about it, you've seen other cases where they've got just as much space anteriorly as they do posteriorly, right? This person has lots of CSF here. Anteriorly, it looks like it's a little bit less, but they're still calling it normal. They still see CSF around both anterior and posterior aspects of the spinal canal. There's really no degenerative change. They call this normal. This is one of their examples for grade 1, which, probably would use as mild, where you do have effacement of the CSF, but there's no flattening of the spinal cord. There's no myelomalacia. And again, there's degenerative change causing this, right? So grade 1, grade 2, where you've got this degenerative change, you've got effacement of CSF, but you've also got some distortion or flattening of the spinal cord. And then for grade 3 or severe, you've got disc, you've got flavum hypertrophy, you've got compressed cord, and you've got signal abnormality. So I will not suggest that I am perfect in this every time. Like I have probably called moderate when really it was only mild. I think, again, the patient's presentation and the clinical symptoms are really important. And, talking about this, maybe it is a good time among our neurorads to have a discussion in terms of like what grading system are we going to use, and can we not only be consistent internally, but amongst ourselves, so that every time you read a spine, you're calling it the same way, but maybe we could have some internal consistency among the radiologists in our group as well. I'm going to stop there, guys. We're already over time. I apologize. Yeah, lumbar spine degenerative change, the takeaways. If you could read that Nomenclature 2.0 paper from 2011, please tell me if there's a 3.0 version. As of last year, there wasn't, but I will admit I did not check this week to see if there was. And then that Miskin and Mendel grading system. Let me show you the paper again. I really enjoyed from 2011. I thought that was a great paper, and thanks to our fellow Tyler to showing me that one a few years ago.
Shauna, thank you so much. That was fantastic. There is so much here which has made me tear my hair out on a daily.
Tear your hair out? I can tell you, Derek, there have been days where maybe I'm tired, having a bad day, and I'm like, oh my God, is this a protrusion or extrusion? And I just have to stop myself.
But you really clarified a lot of it, and I'm so grateful, because this
is fine.
You use this daily. We do so much of it, and often it's not well done, but this has really clarified a lot of it. This was a great lecture. Thank you.
Yeah, thanks, Derek. And again, I won't claim to be perfect, but at least Charlotte and I reviewed some cases and talked about internal consistency. It's important. It'll just make your life easier if you kind of decide what you want to do kind of early on. So, anybody else?
Thank you, Dr. Kennedy. This was great. Very
All
helpful.
right. Thanks, guys. And if we have time later, maybe after our colleague from Montreal gives her presentation, we can also look at my my cases for cord signal abnormalities. All right, we're all finished. Thanks everybody for coming.
Thank you, Shauna.
Thanks, Ewan.